बिस्मिल्लाहिर्रहमानिर्रहीम। आज का लेक्चर उन लेक्चर्स में से एक है जो मैं समझता हूँ कि मेरे प्रैक्टिसिंग फिजिशियन कॉलीग्स के लिए बहुत हेल्पफुल होगा, क्योंकि मेरा एक्सपीरियंस ना सिर्फ पाकिस्तान का है, सऊदीया का भी है और उसके बाद मैंने अमेरिका में भी काम किया। सो मैं बड़े अच्छे से समझ सकता हूँ about the billing techniques in different healthcare systems. And I will try to share my own experience, what I did after I came back to Pakistan. So today's topic is about outpatient evaluation and billing technique that I followed after coming back to Pakistan. This is my personal experience and how I do it. Actually, you can do the way you feel comfortable and make some amendments according to your specialty. But I think it would be very helpful for doctors to understand, and also it will be helpful for my patients as well to understand how I bill my patients. So let's start with presentation for today. So the first technique, I call it short and sweet. As you can see, the time is ticking. So it is fast. What happens, and I also kind of tend to remember it by my colleague, David Uskovich, who actually showed me how to kind of follow this particular technique. Usually there is a template, you quickly go through those set of questions. This is a subspecialty kind of clinic, but it's mainly you see the simple neurological issues, try to finish them as quickly possible, stick to those particular set of questions, and if needed, then refer the patient to a subspecialist like a multiple sclerosis or a neuromuscular subspecialist. So it doesn't take a whole lot of time, 15 to 20 minutes would be enough, but this is short and fast. The next technique is just enough and addressing main issue. I tend to remember this technique from my colleagues, Lisa Herman and other colleagues as well, also used to practice, where they particularly look at that complaint patient coming in with. In that particular case, you again stick to the questions. You may go around a little bit to understand better about the psychological or the social situation of the patient. But again, you try to get enough detail to address the main issue and don't ask or get into the details for any further problem the patient may have. And if needed, then patient can be referred to other specialty or a subspecialist. It may take up to 30 minutes to see a patient in this way. But what I usually do in this particular case, if patient tend to tell me, okay, doctor, I have headache, but I'm also having diabetes, and I want to discuss about polyneuropathy. So I just talk to them, see, this visit, we're going to discuss about headache. Next time, we will talk about polyneuropathy. Or if they say, I have sleep issue. Now, sleep is another subspecialty of neurology. So I tend to tell them that today, what we're going to discuss is the main issue which is bothering you and brought you in the clinic for evaluation. Next time, we will discuss about the other complaint. First, we have to handle the active issue for you. And as I said, it may take up to 20 to 30 minutes to see this patient in an outpatient setting. Next technique is a subspecialist style. And I will tend to remember this technique from my colleague, Amanda Peltier and Peter D'Onofrio in a neuromuscular clinic. It usually takes 45 minutes, even more, to see these patients in clinic. So you try to get this kind of slow sailing boat. So you have to get the detail, you have to go around the social issues, because it's a life-changing kind of questions and issues to address. So I kind of go into more details about the social scenario, job situation, family support, and those kind of things. And then you talk about the treatment plan, and many times those medications have side effects. So we have to discuss about the side effects of these patients. So my patients, sometimes they ask me how I spend this much time with one patient, because this is not usual in Pakistan. So it may take up to 45 minutes to 1 hour to see a subspecialty patient. But as I said, it involves a whole lot of details, not only pertaining to the problem, but what else is affecting the quality of life of the patient. And then the treatment modalities, rehabilitation, and all those issues need to be discussed in this particular case. The next technique, I call it slow and steady. And I tend to remember my colleagues from Vanderbilt, Andre Lagrange and Michael McLean. So one line I remember from them is that if you don't know what's going on, then you try to beat the hell out of that particular complaint of the patient and get as much information from the patient as possible. This is very normal for physicians. None of us knows everything. So what happened is, if you don't know what's going on with the patient, you try to get as much information from the patient, try to consult with other colleagues and see what's going on. It may be some rare disorder. It may not be very obvious in the start. And with the passage of time, especially in neurological disorders, time is the key. And after some time, things become more clear. So as there are pieces of the block and there is one piece missing, so you try to look for that particular piece to kind of put everything together. So it's slow and steady process. It may take longer. It may take up to 1 hour to see a patient. You still may not know what's going on, but I think being upfront with the patient is very helpful in this particular case, and let them know that I don't understand what's going on. It is very possible, even with the subspecialist, that they don't know what's going on or what particular acquired or genetic neuromuscular condition patient is having. But being upfront and confident about what you're telling them is very helpful. It's more of a funneling approach where you start big and then you gradually come down to the final diagnosis of the patient, and it gives confidence to the patient. And naturally, it's a learning experience for the physician as well. Coming next is the billing techniques in the clinic that I follow. And I'll kind of go over, and I will particularly like to remember my colleague, Chris Lee, who taught me about the billing techniques very nicely. So what usually happens in an outpatient setting is you tend to see routine and urgent cases. The emergency cases should be seen in emergency. So the billing I tend to follow in my clinic in Pakistan has mainly routine and urgent billing patterns. And naturally, with the urgency of the case, the bill may vary. So coming to what I tend to do with these patients. So first thing, is it a routine case or urgent case? That may change the bill. Also, the other modifiers to kind of adjust in that equation is based on complexity. So if it's a simple case, but it's urgent, it may not be charged as high. Unless it's a complex case and it needs to be seen urgently, then the charge is going to be higher. Then comes the insurance billing, because if it's an insurance kind of payment that I'm gonna get, it takes longer to get the money from the insurance. It has to be multiple bills you have to sign. So in that case, the bill may be a little bit higher compared to a routine out-of-pocket payment. This is the model which is followed in the US as well, and that's the reason the insurance paid bill are charged higher than a regular out-of-pocket bill. And I think that people in the US understand that very well. So if somebody want to have the insurance paid the bill, then it may be charged higher than a regular bill. Next modifier is based on social welfare. So naturally, as a physician, we have a humanity component. We always try to help patients who are having difficulty in paying. They don't have an insurance. It's hard for them to pay big bill out of pocket because they have to get their medications and also to do some tests as well. So in that case, you tend to reduce the payment. In corporate sector, there may be a social welfare department, but I tend to do it because my clinic is a single entity. So I tend to do it for my patients with a billing software. And I try to kind of cut it down based on how much they can pay. If they are unable to pay at all, then I will may reduce it down to a zakat based. And if it is they have some paying capability, then I will reduce it 50% or more. So I tend to follow these two patterns in social welfare. Then comes the patients who are having some protocol or they are VIPs. So in this particular patient population, they do need care. So we need to understand that part. But what happens with those patients is that when they are coming, they are having time crunch. So they need some time adjustment. And when they're coming into the clinic, because of the security issues and other things, I have to make some clinic adjustments. So they are also charged higher than a regular patient. And I'll say I have been very comfortable with my patients since I came back to Pakistan, because most of my patients, if I'll say almost more than 95% of my patients understood what I'm doing in terms of the billing. I have been very lucky that they understood that point, and I have practiced it in Pakistan very successfully. So you can have your own model, but this is a model that I practiced. Then there is a billing table. I took off the charging numbers. You can have your own numbers, but I tend to divide the pathology as simple and complex, as I have already mentioned. And this is right at the front desk, so the people know what they're going to pay. It may change a little bit, but based on the urgency. But otherwise, for simple cases like headache, pain syndrome, epilepsy, stroke, I usually charge a lower amount. For patients who take longer, because in sleep patients, you have to do a sleep questionnaire. For multiple sclerosis, it takes much more detail. Same goes for neuromuscular and movement disorder cases like Parkinson's disease. In dementia, you may have to do the memory testing, which takes a good amount of time. And neuro-ophthalmology cases, because those are complex. So these patients are charged higher because of the reason, because they are complex, they take longer than usual. So I kind of tend to tell my patients that it is a time-based service. If it takes longer for me, then it will be charged higher. And actually, complexity is one thing in that particular scenario. What I also tend to do to recognize teachers and hafiz, I give them discounts separately without they tend to mention it to me. So I think it's a one way to pay back the community, because teachers and hafiz, they are very prestigious, and I like to give them extra respect. And then come the procedure billing. So in neurology clinic, we tend to do small procedures. These are invasive procedures, but not the big ones. So lumbar puncture is one. If I'm checking opening pressure, is different. If it is just a simple lumbar puncture for meningeal encephalitis, it's going to be different charge. If it's Botox with EMG guidance, it will be charged differently. Otherwise, it will be a simple Botox. Same goes for the nerve block. Follow-up fee is kind of standard for all the patients that I have. Unless it takes longer than a usual patient, or if there is a new complaint patient want to talk about, like what we discussed before, a patient coming in with a headache complaint last time, and now this patient want to talk about polyneuropathy. So in that case, it's a new complaint we are addressing, so it will be charged higher than a regular follow-up. Now, the urgent consultation fee, as I have already mentioned, are divided into simple and complex based on the pathology, and naturally it takes longer, and I have to make some adjustment to see these urgent patients in a routine patient flow of the day. In US, they have much more advanced billing system because of the insurance and a lot of other issues. So they follow the coding pattern. So there is an international classification of diseases, and the recent manual is 11. And all the diseases, all the patients we see have to be divided or need to have a code. So that code, it decides the billing for the patient. And then there are other modifiers as well, which I'm not going to talk about, because I'm just talking about the billing practices that I have done in Pakistan in my own clinic. So at the end, what I would like to say is that it is not that simple. The way I explained it, naturally, there are a lot of things to consider, but more importantly, it's the intention of the physician, what they are trying to do. So my intention is to help my patients, but naturally at the same time, I have to make some charge as well to keep things running. So I think we all as physicians tend to help our patients as much as possible, and they do understand this point very well as well. Thank you very much. You can see this is a card drafted by me with the help of my brother who helped me out, and we want to have the cultural background to the card, to the business card, and also have my information on it. We are on YouTube. We are also having a website as well, as you can see. So all these things happen gradually, but gradually you get to the point where you feel comfortable and happy about what you have done for your patients and as a professional. Thank you very much.